Good afternoon, good morning, everybody, wherever you are located. Thanks for attending this meeting. This is Juan Gispert, R&D Director at Dentate, and on behalf of Dentate, I'm very pleased to welcome today Professor Mariano Sanz and Professor David Herrera to this session of Aula Dentate Stay at Home, where they will review the relevance of oral cavity in the COVID-19 pandemic. I will try to make it short, but I will introduce both of them in a few sentences. Mariano Sanz is professor and chair of periodontology at the University Complutense of Madrid. He is invited professor in Oslo and Bern. He received honorary doctorates from the University of San Sebastián in Santiago, Chile, University of Göteborg, Coimbra, and Buenos Aires. Since 2005, Professor Sanz has been chair of the ETEP, at the University of Madrid, the research group on the etiology and therapy of periodontal diseases, associate editor of the Journal of Clinical Periodontology and Evidence-Based Dental Practice, member of the Executive Committee of the European Federation of Periodontology, and chair of the Workshop Committee. Professor David Herrera has a degree in dentistry, master in periodontics, and PhD in the Complutense University of Madrid, when he currently acts as associate professor of periodontology, responsible for all the postgraduate trainings in periodontology, vice-dean of clinics, and co-chair of the ETEP group. He has served as chair of Spanish Society of Periodontology, SEPA, and different committees of EFP, the European Federation of Periodontology, and the International Association of Dentistry Research, where he currently is part of the board member. Please join me in welcoming both of them to this session. Just one point, just one housekeeping message. Our speakers are kind enough to go through the questions that you will be adding in the chat. Please keep the chat free from personal messages and add any questions that you may have related to the COVID and oral cavity. Thanks for your time, and Professor Sanz, really up to you.
Okay. Good afternoon or good morning, wherever you are. It is a great pleasure for me to share this webinar together with Professor Herrera and address to you in a way dealing with a topic that we have been sort of eating breakfast, lunch, and dinner for the last 2.5 months. So basically, we are all specialists in COVID-19 all over the world. But we are also interested in understanding a little bit deeper what are the connections and interrelationship between this very important infection that has affected our lives and our way of living and the oral cavity, which is our profession. So in the first part, the first 15 minutes, I will try to deal with general knowledge on the COVID infection. Most of the things that I would address to you, you probably know already, but we felt it was important to share some general knowledge on the virus and on the infection in order to understand what are the implications to the oral cavity and to our work, which is the part that Professor Herrera will convey to you immediately once I have finished. So let's start. What do we know about the coronavirus? Why is it called coronavirus? Well, basically it's called coronavirus because of the image that you see, which is the image that we see of this virus on electron microscopy. And when we watch the virus with electron microscopy, we rarely see this crown, which is basically the result of the spikes, these small clumps that this particular virus and all the family of coronaviruses have on the external surface. But what is important about this virus is not only the crown, but also its high infectivity that is able to enter the host cell and replicate, shedding out thousands of copies of the virus, which spread rather fast. So let's describe very simply this particular virus. And as you can see, this particular virus is a single-stranded RNA virus with a very small diameter, basically around 100 nanometers, extremely small. And you understand that viruses, different from bacteria, are not cells. They are basically proteins and genetic material, which is set up in a way that can only survive if they get into a cell where they can replicate and when they can basically expand with thousands and thousands of copies. So in order to maintain the life of a virus, basically the virus needs to replicate and to produce certain proteins which are able to protect this genetic material from the extracellular and intracellular environment. And you see, this is very simple. The virus has the RNA, the genetic material, which is basically surrounded by a nucleocapsid, which is composed of a protein N. And then this nucleocapsid that protects the RNA material is at the same time protected by a membrane and a capsid. And this membrane and the envelope basically protects the nucleocapsid from the external environment, and at the same time is able to maintain together the genetic material. And you can see that these coronaviruses have these spikes, the S protein, and these spikes are composed of basically two major proteins, S1 and S2. One of them basically is the receptor binding domain that you can see here, the 3D molecular configuration, which basically adapts very intimately with a very specific receptor that many cells have, most of the cells of the mucosa, and Professor Herrera will expand on that, which is this angiotensin converting enzyme 2 receptor, what we call the AC2 receptor, which is a very important component of our mucosas. So basically, if we look at the composition of this virus, you see that it's very simple. It's composed basically of 4 different proteins, which make the structure of the different areas of the virus, the nucleocapsid, the membrane, the envelope, and the spike. And then inside is the genetic material. Are these viruses very common, the coronaviruses? Basically, has been described 7 coronaviruses affecting human beings. 4 of them are very common to us. They produce very common kind of very mild respiratory infections. But the ones that have attracted our attention because of the transmissivity and the virulence, first one is the SARS, the severe acute respiratory syndrome virus, that, as you see, was identified in Asia, in China actually, in 2003. And it was the one that first it was described that was developed in an animal and transmitted to humans. Then some years later, basically 10 years later, it was the MERS, the Middle East Respiratory Syndrome virus, which the animal that was the housing of this virus were the dromedaries. And this virus was basically identified in the Middle East. And then this is like a 10-year cycle. About 8-9 years later, we have the COVID-19. And this novel coronavirus, as you very well know, was identified in China. And it's still not very clear which was the housing animal for this virus, but either a bat or a snake or a pangolin have been the animals where these viruses has been developed, and from there has been transmitted to humans. So basically, when we are dealing with any virus that affects human being, we need to know what is the source of the infection, where the genetic material of the virus is developed and muted. And these, we know that there are basically bats that nest these viruses. Normally, these bats have direct contact with an intermediary host. We don't really know exactly whether it is the pangolin or a snake or other, but it has been related with these markets in China where they sell live animals. And from there, of course, very close contact with a human being, then the virus gets connected to these ACE2 receptors, and then the whole thing explodes because of the very high transmission of this virus from human to human. So we understand the source of infection, the transmission, and the route of this transmission. And finally, we need to understand how is the susceptibility to this virus. And we have known that this virus does not affect everybody the same manner, but those people who are more susceptible are those that are old and have comorbidities, where hypertension and diabetes, perhaps smoking, have a lot to do. And of course, we from the oral environment, we always think that perhaps periodontitis could be another source of susceptibility, since, as you know, periodontitis is linked with systemic inflammation. And systemic inflammation is one of the characteristics of this viral infection. Anyway, you see this graph, how the mortality has affected, mostly old people. We know very well how this virus spreads, basically with these small droplets that we expel when we cough and we sneeze, and also the importance of surfaces. This is not a virus that goes via the air or via the body fluids as HIV or as Ebola viruses, but it needs the surfaces that they will stay alive for some hours, and the direct contact is what makes this virus transmissible. But you see this picture, which is basically a human cell expelling thousands and thousands of copies of viruses. So once the virus gets into the cell, it can be highly transmissible. So we know very well how is the infectivity of this virus. And basically most of the strategies to control the viruses come from knowing that a very specific protein from the spike, the S protein, binds to this ACE2 receptor. And then there is another protein, the S2, which fuses the protein to the protein of the membrane. And then by endocytosis, the virus gets into the cytoplasm of the cell. And then basically the capsid and membrane proteins dissolve, and then the genetic material gets into the cytoplasm of the cell, gets adapted to the Golgi and the ribosomes, and then copies and copies and copies of the proteins that make the viruses will replicate by glycation, and then new copies of the viruses will be produced and expelled out of the cell. Basically, when this is the viruses that you see by electron microscopy, and this is how they attach to the cell and they fuse to the membrane of the cell. This is the domain of the S protein that is responsible to this adaptation, and this is the key domain that we need to counteract whenever we have a vaccine. And you see here the thousands of copies of the viruses, these small orange dots that are coming out of the cells. And here you see that we have many, many more viruses that cells in the environment. So this cell is highly infected by the viruses, then the cell will die, and then of course the symptoms of the patients will occur. I'm not going to repeat something that you know very well. What are the symptoms associated with these viruses? Basically, there are several symptoms that are very common, and what we don't know is why normally it is a mild disease affecting 80% of those who get infected by these viruses. About 14% develop severe disease, and severe disease, according to WHO, is the bilateral pneumonia that normally needs hospitalization but doesn't need ventilation, doesn't need to go into the intensive care units. But about 5% becomes critical. This is when there is a need of the intensive care units, and many people have died, as you very well know. Basically, we are in a pandemic situation all over the world with different graphs depending on the different countries and different situation depending on the different politics. But of course, we are all hoping that someday we will have so many people immunized that the whole pandemia will basically collapse by the herd immunization of the population. But as you know, this is more a dream than a reality, because at least countries like Spain or France, the current statistics is that less than 5% of the people have been immunized. So we are still under a lot of danger of transmission. You understand that the prevention of coronavirus is based on social distancing and very specific preventive measurements. And you also understand that there is no specific antiviral therapy for this virus. And this is why so many therapies have been tried, and basically most of the treatment is still symptomatic. And of course, in the critical situations, there is a need of oxygen supply and mechanical ventilation and hemodynamic support. We are all hoping to have a vaccine soon, that will be the answer to our problem. We don't have a specific antiviral therapy for coronavirus. We are using antiviral therapy that was proved to be very successful in Ebola virus and also in HIV, and is responding quite well, mostly remdesivir, to some of the symptoms of this virus. You understand that it was a big hype at the beginning with the use of hydroxychloroquine. Now even WHO has forbidden its use because it's associated with higher mortality. So you see, also another strategy is to enhance our immune system, basically by interferon or by some of the antagonists of the pro-inflammatory cytokines, and of course also using plasma from patients that have been immunized already. Perhaps the most exciting aspect from science is this huge race for a vaccine that basically will provide us active immunity against this virus. And if you can see this graph, basically it tells us that there are basically two major strategies for a vaccine. Either use a modified virus or a modified virus particle and basically inject it to humans and develop active immunity, or what is more common, more modern, and probably will be the best answer, it will be basically to use the blueprint of the RNA that produces the S protein. And once our body produces the S protein, our own immune system will develop the antibodies to block this S protein. But basically, either the strategy of using virus particle or attenuated viruses, or the RNA that is vehicled through an attenuated virus, we need to test in animals. We need to see whether the immune system produce antibodies to these vaccines. And then we need to go through the phase 1, phase 2, and phase 3 clinical trials in humans until we understand that it's absolutely safe and that is effective in the production of antibodies. There are about 5 different vaccines currently finishing phase 1 and starting phase 2, and could be that by the end of the year we will have a possible vaccine. Probably the one that is more advanced is what is called the mRNA vaccine, the messenger RNA vaccine, which basically, as you understand, it gets a little bit of the genetic code of that virus, that is specific part of the code that basically encodes for the S protein, and then this specific code is packaged on adenovirus, an adenovirus that is modified and unable to cause any disease in humans, but is able to enter the human cells. So if this genetic material is inside this adenovirus, once it's injected in the person, and once this adenovirus gets intracellularly, this small genetic code will replicate many times and will develop in our own cells the protein that will lead to the antibodies that are needed for our immunization. So as you saw in this very small presentation, I was able to deliver to you what is the structure of these viruses, how they transmit, how they infect, what are the symptoms they produce, and what are our current strategies for prevention and therapy. And the most exciting probably is what are the different strategies to develop a vaccine that most likely will take care of this pandemic as soon as possible. So with this, I will transfer to Professor Herrera that will share with you what do we know of COVID and the oral cavity. And I thank you for your audience, and I am happy to answer as many questions as you would like. Thank you very much.
Thank you very much, Mariano. Well, first of all, it's a privilege to be here this afternoon, morning, night, wherever you are, and be part of this session, which I believe it is very interesting. So far, the presentation of Professor Sanz was setting the ground for discussing about this SARS-CoV-2, the COVID-19, and my role will be to go to the oral cavity and discuss about the possible role of SARS-CoV-2 or the oral cavity in the pandemic situation that we are living. So I will share now with you my presentation, and as you have seen, the first part of the presentation was more general, but now I'm going to focus on the oral cavity, and I'm going to focus on the oral cavity based on 2 reasons. First, because the oral cavity is one of the entrance to the body of SARS-CoV-2, and therefore it may be that the mouth could have a role, either protective or an aggravating factor in the infectivity and or in the progression of the viral infection. For that, we need to understand that there is evidence to support that the oral cavity and its mucosae may play a relevant role in the transmission and pathogenicity of SARS-CoV-2. On the other hand, and this is something that we already know, chronic systemic inflammation is associated with periodontitis. So this may represent an added risk to increase the severity of COVID-19 in periodontitis patients. This was already a question that was presented by Dr. Danewit in the chat, and we will discuss that later because I will not cover this part specifically. I will focus on the role of the oral cavity and its mucosa in the transmission and pathogenicity of SARS-CoV-2. So already mentioned by Professor Sant, ACE2 is the primary receptor for the viruses. And it's been shown that there is high expression of ACE2 in the lungs, in the intestines, heart, or kidneys. But what is relevant for us today is that there is also high expression of ACE2 in epithelial cells in different oral cavity mucosa, including, and this is very important, the tongue mucosa. So this may suggest that the mucosa in the mouth may be critical for the onset of COVID-19. We should remember that approximately during the first 10 days, a patient may be infected, but is asymptomatic. And during that time, the patient can be highly contagious. And during those days, virus accumulates mainly at the nasal, oral, and pharyngeal mucosa, and only later will further progress to the lungs. In addition to the nasal, oral, and pharyngeal mucosa, there is evidence to support that the ACE2 receptors are more frequent in the salivary glands actually than in the lungs. So salivary glands may act as a reservoir area for SARS-CoV-2 in asymptomatic patients. So we have, therefore, the chances of having a lot of viruses in the oral mucosa and also in the salivary glands. And we have to understand that the main routes of transmission are related with saliva. So we have these famous fluid droplets, which are the small ones, less than 5 microns in size. These are expelled when doing normal life things like breathing, talking, sneezing, or coughing. And these are big, so they will settle down rapidly. So they will probably settle down in some surfaces. And through these surfaces, our hands may be contaminated and then go to our bodies. But then we also have these smaller particles, which are the Wells droplet nuclei. These are less or equal to 5 microns, also expelled when we are breathing, talking, sneezing, or coughing. And these particles can remain suspended in the air for significant period of times, and even being able to travel farther than 1 meter away. So this justify the transmission from person to person. And in this very simple graph, we could see both types of particles. Here we have the smaller one that could stay in the air and fly to even 2 meters around. And then we have the largest droplets that actually will settle down, but can contaminate different objects that if we touch them and then we bring our hands to our faces and our mucosa, then it can be transmitted. So how the oral cavity can be relevant in the transmission in the pathogenicity? Well, we discuss more about the transmission, but this also may be also very relevant for the pathogenicity. And with this letter to the editorial Lancet Infection, the authors concluded that the oral viral load of the virus was associated with the severity of COVID-19. So if we are able to reduce the oral viral load, it may be possible to reduce also the severity of COVID-19. This is in regards with the pathogenicity, but let's discuss about the transmission. If we are able to decrease the oral viral load, then we will reduce the amount of viruses which are expelled by the droplets. So we will be able also to reduce the risk of transmission. And this may be justified by what we have already said. First, that during the first 10 days, the virus mainly accumulates in the nasal, oral, and pharyngeal area. Second, that the ACE2 receptor number are greater in the salivary gland as compared with the lungs. And third thing, that the salivary droplets represent the most relevant transmission route. So this is further emphasized within the dental practice for oral health professional, because in dentistry, when we are practicing dentistry, there's a frequent production of aerosols. So these dental procedures may enhance the risk of transmitting the virus if it is present in high amounts in the oral cavity. So what can we do? Well, there's one thing that has been or is frequently recommended in all the protocols when practicing dentistry, which is the use of oral antiseptics as a pre-procedure rinsing in order to reduce the amount of viruses in the aerosols. We have evidence for many years to support the use of this pre-procedural rinsing to reduce the amount of bacteria in the aerosols. And the most frequently recommended products or agents were chlorhexidine, the most active, and also essential oil mouth rinses. Actually, a recent systematic review concluded that there were some different agents which were efficacious in reducing the amount of bacteria in the aerosols. And as you can see here, the most effective one was chlorhexidine, but also in the list we can see acetylpyridinium chloride and essential oils. Okay, but for SARS-CoV-2, we don't have evidence. We don't have direct evidence of the impact of a preoperative rinsing in the viral load of SARS-CoV-2. And we also do not have any relevant study evaluating if the extended use of these products for 2 weeks, for example, will be able to reduce the oral viral load of SARS-CoV-2. Therefore, the only way in which we can evaluate this aspect today is on indirect evidence. So I will try to go through the most frequently recommended agents for as preoperative rinsing in these protocols that we are following today in the clinical practice, and try to analyze with you which is the evidence supporting their use. So I will start with the one which has more frequently been recommended, which is povidone iodine. So it is the most frequently recommended, as I said. However, it has very limited substantivity. It has very limited anti-plaque or anti-gingivitis properties, but there are studies, mainly in vitro studies, supporting its virucidal activity against different viruses. But the ones that may be more relevant for us today is those coronavirus closely related with SARS-CoV-2, which are MERS and SARS coronavirus that were explained and described before by Professor Sanz. There are a number of studies for povidone iodine, mainly performed in Germany by one group. And of course, none of this study has been performed with SARS-CoV-2, but we have one study, in vitro study with MERS-CoV-2, and another one in use as gargle or mouthwash also on SARS and MERS, showing nice activity. And there are also a series of studies carried out in Japan in which the povidone iodine was showing in vitro activity against different viruses, including coronavirus. So the use of povidone iodine in the oral setting to reduce the amount of viruses is based on these in vitro studies. Then we have acetylpyridinium chloride, which is a cationic quaternary ammonium is not only an antiseptic, but also a tensioactive agent, which is a good property. And it has demonstrated relevant antibacterial, anti-plaque, and anti-gingivitis properties. With regards to viruses, we have this interesting study which combined in vitro data with preclinical in vivo evaluation, in which influenza virus was shown to be susceptible to acetylpyridinium chloride, both in vitro and in vivo. There was no direct information with regards to coronavirus, to any type of coronavirus. But we have also this very interesting randomized controlled trial in which a acetylpyridinium chloride-based formulation used for inhalation was evaluated in the prevention of upper respiratory tract infection, which they're caused by a range of viruses, and the product was shown to demonstrated effectivity, and the onset, severity, and duration of this upper respiratory tract infection was reduced with the use of a CPC, acetylpyridinium chloride product. More recently, with an approach which is called throughout screening, in which a number of antivirals were tested against different viruses, and specifically one of the viruses is a coronavirus, MERS coronavirus. Acetylpyridinium chloride was ranked as the 9th with the best virucidal activity, and the others may not be very common to use in an oral setting. Another very relevant agent in general, of course, the most powerful antiseptic agent is chlorhexidine, which has shown antimicrobial activity and also virucidal activity, very relevant antibacterial, anti-plaque, and anti-gingivitis properties. However, its antiviral activity against SARS-CoV-2 is controversial. Why? Why? Because at the beginning of the pandemic, two narrative reviews from Chinese authors suggested that can be used to reduce oral transmission, but other studies have shown that the spectrum of action of chlorhexidine against viruses may not include enveloped human coronavirus. So it is a virucidal, but normally inactivate lipophilic viruses, but normally will not be effective against enveloped human coronavirus, at least as explored in vitro studies. Then we have hydrogen peroxide, another very frequently recommended agent in controlling SARS-CoV-2. However, no relevant evidence is available to support its use. It has very limited sustainability in the mouth, and it has very limited impact on dental biofilm. So it is not clear why this agent is so frequently recommended in the protocols. And final comment on essential oils. It has demonstrated in the past that can control herpes viruses, but there's no evidence or not studies or not even indirect evidence with regards to SARS-CoV-2. And probably this is the reason why it has been seldomly recommended in those protocols in the COVID-19 context. We have also some comparative studies that are not simulating the oral mouth scenario, but they are really focusing on inanimate surfaces. For example, this is a narrative review including 22 articles on the effect of different products on inanimate surfaces, including metal, glass, and plastic. And the justification for that was that some coronavirus, including SARS and MERS, can persist in those surfaces for up to 9 days. So different products were in vitro tested, and the results, so the conclusions, they highlighted that in these inanimate surfaces, hydrogen peroxide or ethanol are very effective, while chlorhexidine or benzalkonium chloride are also effective but less effective. But another study, and this include SARS-CoV-2. This is a letter to the editor of one of the Lancet journals, and this is on SARS-CoV-2, but again, activity over surfaces, inanimate surfaces, and it shows that both povidone iodine, chlorhexidine, or benzalkonium chloride, which is closely related with cetylpyridinium chloride, were effective against SARS-CoV-2 in inanimate surfaces. So, with all this information, what can we conclude? Well, you have seen many recommendations from health authorities for protocols when treating patients in the dental clinic. I'm sharing here with you the one by the Council of Dentistry in Spain, and they recommend to have a protocol rinsing with cetylpyridinium chloride, hydrogen peroxide, or povidone iodine. So these recommendations, as you have seen, are mainly based on indirect evidence, and among, for example, the 3 agents listed here, povidone iodine is the one which has more evidence, but only derived from in vitro studies. And also remember that it has very limited substantivity in the mouth and very limited antimicrobial activity in general in the mouth. For hydrogen peroxide, we have almost no evidence. And for cetylpyridinium chloride, we have some in vitro evidence and also some in vivo evidence that may support its use as a pre-rinsing, as a pre-procedural rinsing. And well, this may be very relevant in the scenario that Professor Sang has described. We have no treatment, we have no vaccines, we have a huge problem with this SARS-CoV-2 and the disease COVID-19. So if we have something that can help us on one hand, decrease the disease severity by reducing the oral viral load, or by decreasing the risk of transmission in the aerosols or in the droplets, in the aerosols generated during the dental procedures, or in the droplets that are generated in the normal life activities, such as breathing, talking, or sneezing, or coughing. Well, if we have agents that will allow this to happen, it will be very helpful in order to decrease the severity of the disease and in order to decrease the risk of transmission. But I have said, as I have said before, the evidence to support these conclusions or to support the recommendations are so far missing. We are missing well-designed clinical trials, which we can. And in the meantime, the only thing that we can do is use this indirect evidence to use the base available evidence to provide these recommendations. So this is actually my last slide. I would like to thank you for your attention. And as Professor Sang has said, we are open to discuss any question or any doubt that you may have. I think we have a problem with the sound here, but
I can hear David, but I cannot hear Joan.
I think that in the meantime, Mariano, if you want, there was a question already set when you were speaking by Professor Bettina Danewit, and I think it's a very relevant thing that we have already discussed, and it was for you that if people with untreated periodontitis is at higher risk of getting infected with SARS-CoV-2 due to the presence of the ulcerated pocket epithelium.
Well, indeed, This is a very relevant question, and actually there is an effort, international effort. Study is being designed. Basically, the problem we have is to access the relevant people, which are those 14% that have had severe disease, and these 4% that have had critical disease. Because the question is, did periodontitis influence that these people became severe or critical? And therefore, we need to access these people and then, of course, compare those who, having become severe or critical, have periodontitis and what is the severity of this periodontitis, and try to evaluate all possible confounding variables that we could identify and make a multivariate analysis with enough sample population so we can identify a clear association. This study has not been done, or at least it has not been published yet. But we are working together with some colleagues from China, from Qatar, from Montreal, and from Madrid to be able to design this study. The study is designed, and now we are doing ethical committee approval in some of these sites. The critical thing is that it's not so easy to access to a periodontal examination of these people, because these people, some of them are still in the hospital, some have been cleared from the hospital, and therefore the first attempt is going to be through telephone interviews using a self-reporting questionnaire that has been validated internationally. And hopefully from there we can continue accessing for periodontal examinations and being able to undertake these investigations, which probably will tell us whether this is plausible or not. Of course, we think it is, because it makes all the sense that severe periodontitis that is clearly associated with systemic inflammation. And since this cytokine storm has been one of the clear signs of severity and associated with the critical illness of some of these patients, that perhaps this hyperinflammation has something to do with the disease status of the oral cavity and the periodontitis in particular.
Okay, thank you. We have here another one for Professor Herrera. What about hypochlorous acid? Can it be used in the dental chair reservoir to reduce viral load in aerosol?
Thank you for the question. I think, I have not covered all the possible agents that could be used. I have just covered those agents that were more frequently recommended in the guidelines of different organizations all over the world. Chlorine was not in that list. In addition, probably chlorine may be more useful in surfaces or in maybe in the reservoir, in the liquid reservoir of the dental chair. But you have to. This cannot be answered properly, because when you are using this type of agents for those in those indications, not in the mouth, but in disinfecting the dental chair reservoir, this could have secondary effects for the working unit. So I don't have a clear answer for that. Chlorine has not been tested, or the information as a virucidal agent in the mouth. And of course, as a disinfectant in surfaces or in the reservoirs, it could be useful, but I don't know how will that interfere with the functionality of those systems.
Okay, thank you. We have, sorry to go back with the same Professor Sand, but there is a remark asking, the question was more related on the question if the periodontology people are at higher risk to to suffer COVID-19 or not?
Yes, I was actually reading now secondarily this further questioning from Bettina. I don't know, but in the same way that I see clear plausibility that periodontitis might be an aggravating factor of those infected, I do not see a clear plausibility why periodontitis people will get more infection, because a viral infection is related from the closeness from somebody who is transmitting the disease, or the availability of a high viral load in closed surfaces that are affecting people. The problem I see is that once you are infected, you see that 80% of the people develop a very mild disease. Why 14% develop severe disease? Why 5% develop critical disease? We know some of the susceptibility factors: hypertension, obesity, diabetes, probably smoking. It's not very clear, but most likely smoking. So in this context is where I think that makes sense to me that periodontitis could be an aggravating factor. But I am not sure whether I understand why somebody with periodontitis will get more infection than somebody who's not, provided you have all the closeness, the vector, the transmission, all the conditions that make you infected by a virus.
Okay, thank you. If there are more comments, we can be back to this one. We have a couple of questions that are more or less similar here. One is for Professor Herrera. Does the micromotor produce aerosols? And the other one is related more to possible rules of combining iodine and CPC, or CPC with peroxide of oxygen. What do you think about all of these combinations and the possible inflammations and the dissemination of the disease and the aerosolization of the disease in the box?
Well, first thing, yes, micromotor, turbine, and the ultrasonic devices, they produce a lot of aerosols. I mean, it's an incredible amount of aerosols. There is studies tracing them all over the clinical setting, and you can see those aerosols 2.5 meters around. You could see the whole body of the operator covered with those aerosols. So they go everywhere with all the things that we normally use in the clinical practice. So yes, so this is becoming more relevant than how to reduce the oral viral load in order to have less viruses in the aerosols. Which, by the way, we don't have the information on how many viruses we will have in those aerosols. So we know that they are there, and we know that the aerosols will go everywhere, but we don't know exactly if they are highly loaded or not with SARS-CoV-2. With regards with the combination, I'm not an expert in pharmacology, but I don't think it is possible. So these products are highly charged. So if you combine povidone iodine, or if you try to combine hydrogen peroxide with CPC, probably they will not work. They will interfere with each other, and probably part of it will be inactivated. But I'm not an expert in that. The only thing is that I can say is that whenever you are trying to combine active agents in a formulation, the formulation is crucial. So I remember when chlorhexidine was first combined with cetylpyridinium chloride like 20 years ago, and at the beginning there was a huge controversy on how is that possible. It is possible to combine CPC and chlorhexidine together and make an effective product. That was achieved many years ago, but at the beginning there was a big discussion. So I think you cannot combine povidone iodine or hydroxyl peroxide with CPC.
Okay, there is last question. This for Professor Sand is how can we prevent in the box the aerosol contamination? That's a question we have, I think.
Well, I mean, I will answer in a completely different angle. And this is, we dentists that work under heavy aerosols, all the studies that have been done in the dental hospital in Wuhan in China, the study that has been done in Yonsei University in South Korea, all these studies clearly demonstrate that the dental setting is a very safe setting because the infectivity within these hospitals has been really zero or almost zero. Actually, there is also a very big study coming out from Jerusalem, from Israel, also evaluating thousands of patients going through the dental hospital without any infected patients. Of course, because part of the fact is that we are used to cross-infection control. Since many years, we have activated even stronger protocols of cross-infection control. And in spite of the aerosols and in spite of the close vicinity that we work to the mouth of the patient, the amount of reported infection through the dental setting is almost zero.
Okay, I think we have the last couple of questions, one for each of you. So we'll move to Dr. Herrera just to keep the pace. So Dr. Herrera, several experts from ADA mentioned that preprocedural or rinses will most likely not be effective against SARS-CoV-2 and could create a false sense of protection. What are your thoughts on that?
Well, I don't think what ADA or other experts are saying is that will most likely not be effective. This is not the message. The message is that there is no documented evidence to support the use. That's true. I mean, we don't have a direct study of procedure mouth rinsing supporting that they reduce the load of SARS-CoV-2 or they reduce the risk of transmission. We don't have that. We don't have the evidence. So we have indirect evidence. That is not that they most likely will not be effective. So this is the first thing. And for example, ADA is saying no documented evidence exists. This is what I have said. On the other hand, this is just one part of many different things that you need to do to protect yourself and the patient from transmission. So it's not that you do just rinsing and when you have done rinsing, then you can do everything. You have a lot of protection. So this is just one thing. And this one thing has been included in most protocols, if not all, in most protocols all around the world, from Korea, China, to Spain, Portugal, and South America. So it means that many people believe that it could be useful. Of course, it is not something that will work alone. It's just one added thing. But we need the studies. I mean, maybe in some months we will have some data available that will tell us this is useless or this is working or not working. But remember, this is something that we were doing before for controlling the presence of bacteria in the aerosols. So doing it now for controlling the presence of bacteria in the aerosols and also for controlling the presence of viruses in the aerosols, it makes sense. I mean, it's not that we're not doing something new from scratch. It's something that we have been doing for many years for other purposes, and now we can keep on doing it for an additional purposes. In my mind, and with the data I have shown, I think that maybe CPC can be helpful in reducing or maybe having, for sure, less bacteria in the aerosols. And this is also important because if you have less material in the aerosol, then you will have less viruses because the viruses, they don't travel alone. They need to travel over something, over cells, normal. So I think it is reasonable. And again, I insist, ADA have not said that pre-procedure rinses will not, most likely will not affect SARS-CoV-2. What they say is that there's no evidence. And I agree, there's no evidence, but there's no evidence for 99% of the things that we do with regards with SARS-CoV-2 or COVID-19 at the dental clinics and at the hospital.
Thank you. And last question for Professor Sanz. Could the virus load survive in deep periodontal pockets?
Well, I think the virus have access to ACE2 receptors, which are much more available than the depth of a pocket. So in the dorsum of the tongue, in the salivary glands, in the pharynx, those are the areas where most of the receptors have been identified. So I don't think the virus needs to go to the pocket. I think it has a much easier accessibility to these other areas in our mucosa that are more readily available. This is one of the reasons I don't think whether we have pockets or whether we have gingival inflammation will make us more prone to get infected. What I think is that once we are infected, if we have oral disease, perhaps we will be more prone to develop symptomatology.
Okay, so I think we have no more questions. I would really thank you again for this great presentation. It was needed, was really needed to have this cutting-edge presentation on the knowledge on where we are today. So thanks again. It's been an honor to have both of you helping us in this Aula Dentai.
Thank you. Thank you very much.
Thank you very much. Thank you to all of you.
And stay healthy, please.
Bye.
Bye-bye.